Imagine living in a house where the thermostat is just, well, completely possessed. Like 1 minute, the ambient temperature is perfectly comfortable, you're going about your day, and the next second, the furnace suddenly blasted maximum heat.
Right, just out of nowhere.
Exactly. Alarms are going off in the hallways, you are totally drenched in sweat, and you find yourself desperately throwing open every single window in the dead of winter. And for decades, the medical fix for that possessed thermostat was essentially a doctor handing you a desk fan and, wishing you luck.
Yeah, a desk fan and a lot of patience, which is really frustrating.
It is. But today, we are diving into a massive stack of medical guidelines to find out if there's finally a way to actually fix the wiring. We're looking at documents from the National Institute for Health and Care Excellence, or NICE, along with the Royal College of Obstetricians and Gynecologists and the British Menopause Society.
It's a lot of material to get through, but it's so important.
Definitely. The mission for this deep dive is to answer one really specific, incredibly important question for you, or maybe someone you know. Are there effective non-hormonal prescription medications available for hot flushes?
It's a question that affects just an enormous portion of the population. I mean, hormone replacement therapy, or HRT, it remains the gold standard for treating menopause because it, directly replaces the missing estrogen.
Right, it fixes the actual hormone deficit.
Exactly. But we are looking at up to 500,000 women in the UK alone who are eligible for alternative treatments because, well, HRT simply isn't an option for them.
Because of medical history, right?
Yep.
Like breast cancer?
Yes, a history of breast cancer or maybe a high risk of blood clots. Or honestly, sometimes it's just a personal preference to avoid hormonal treatments altogether.
I was looking at how doctors have historically treated those 500,000 women, and the old guidelines read less like a targeted medical strategy and more like a desperate raid on a random pharmacy cabinet.
That is a very accurate way to describe it, actually.
We're going to explore how the field is finally moving away from that guesswork and entering this really revolutionary era of targeted neurological treatments. But to appreciate this new science, I think we need to look at what doctors have been forced to do up until very recently.
The contrast is just staggering. For a long, long time, doctors relied on a phenomenon we call off-label prescribing.
Right, borrowing drugs.
Exactly. They noticed that certain drugs, which were developed and approved for entirely different diseases, had this, well, unexpected side effect of reducing hot flushes. So they just started borrowing them.
I have the guidelines right here, and let's look at this repurposed toolkit. One of the major categories is anti-seizure medications. Like, I'm seeing gabapentin and pregabalin listed as treatments for hot flushes.
Yes, those are very common off-label options.
But those were originally developed for epilepsy and severe nerve pain. How on earth does an epilepsy drug cool down a menopausal hot flush?
To understand that, you kind of have to look at what those drugs do to the nervous system overall. Gabapentin and pregabalin work by calming down nerve overactivity.
So they just quiet everything down?
Essentially, yes. In the context of a hot flush, they dampen the exaggerated nerve signals that cause your blood vessels to dilate and trigger that sudden rush of heat. And they do show effectiveness, particularly for women who suffer from severe night sweats.
But there has to be a catch. I mean, if you are taking a heavy nerve-calming medication designed for seizures, that just can't be a gentle experience for your body.
Oh, it's not. The catch is severe drowsiness. You're essentially sedating the nervous system. The prescribing guidelines acknowledge how heavy this sedation can be, which is why they mandate a very slow, really frustrating titration process.
Meaning you have to step the dosage up gradually, right?
Yeah.
I see here. It starts low and increases by 300 milligrams a week.
Right, all the way up to a maximum of 1.2 grams.
That sounds like a painfully slow process.
It is. But that slow climb is necessary just to let the patient's brain acclimatize. I mean, think about the daily reality for a woman trying to use this. She is already exhausted from night sweats, ruining her sleep.
Yeah, she's probably running on fumes.
Exactly. And now she has to navigate her workday, her family life, all her responsibilities, while functioning through a thick fog of medical sedation. You are trying to minimize that daytime zombie feeling, but it's a very difficult tightrope to walk.
That sounds completely exhausting. And if the anti-seizure meds don't work, the guidelines point to another borrowed drug, oxybutynin. I actually recognize that name from television commercials. Isn't that usually prescribed for an overactive bladder?
It is, yeah. Doctors typically prescribe it at about 2.5 to 5 milligrams twice daily for hot flushes.
Okay, let's unpack this. We are using bladder medications and seizure medications to cool down the hot flush. It really feels like doctors have been using a Swiss Army knife to fix a very specific plumbing issue.
That's a great analogy.
But why does a bladder pill stop a sweat? Like mechanically, what's happening?
It all comes down to the underlying chemistry, specifically its anticholinergic properties. Oxybutynin blocks a neurotransmitter called acetylcholine.
Okay, acetylcholine.
Right. And in the bladder, blocking that chemical stops the involuntary muscle contractions that make you feel like you urgently need to go to the bathroom.
But that chemical must do other things in the body, too. It can't just be for the bladder.
And that is the core issue. That exact same chemical pathway is heavily involved in activating your sweat glands. So oxybutynin does stop the sweat of a hot flush. It dries you out.
Oh, wow.
But it's systemic. It travels through the entire bloodstream, affecting every single system that relies on that neurotransmitter.
So if it stops sweat, it probably stops other moisture. I'm guessing that means dry mouth.
Dry mouth, severe dry eyes, and chronic constipation, because it slows down the smooth muscle in your digestive tract, too.
So you treat the hot flush, but you create 3 brand new, highly uncomfortable daily symptoms.
Exactly. It is an incredibly blunt instrument.
Which leads us to the antidepressants. The sources specifically highlight a class of drugs called SSRIs and SNRIs. Venlafaxine seems to be a really major player here.
It is. It's very commonly prescribed for this.
I need a quick explain. Well, I'm 5 on this one. I know those acronyms refer to depression and anxiety medications, but what do they stand for, and what are they actually doing inside the brain of someone having a hot flush?
Sure. So SSRI stands for selective serotonin reuptake inhibitor, and SNRI stands for serotonin and norepinephrine reuptake inhibitor.
Okay, serotonin and norepinephrine.
Right. They're crucial neurotransmitters, chemical messengers in the brain. We usually associate them with mood regulation, which is why these drugs are used for depression. But those same chemicals also play a vital role in the brain's temperature regulation center.
Oh, I see. So by tweaking the mood chemicals, you accidentally tweak the body's internal thermometer.
That is a perfect way to visualize it. By adjusting the levels of serotonin and norepinephrine, you can stabilize those temperature pathways. Studies actually show that a daily 75 milligram dose of venlafaxine can reduce hot flushes by anywhere from 25 to 69%.
That's a huge range, but 69% is significant.
It is, and for some women, it has the added benefit of helping with the mood swings and sleep disturbances that often accompany menopause.
But again, it's systemic. You are altering brain chemistry globally to fix a local problem.
Yes, and that global alteration brings systemic side effects. You're looking at nausea, dizziness, sometimes increased anxiety when first starting the drug, or a significantly reduced libido. It is still very much a compromise.
That compromise brings me to what I'm calling the clonidine paradox as I read through these guidelines. Out of all these repurposed drugs we just talked about, clonidine, which is an old blood pressure medication, was surprisingly the only non-hormonal drug officially licensed for hot flushes in the UK for a very long time.
Yes, it had that unique status for decades.
But I have to push back on this because the data looks terrible. The sources say clonidine causes sleep disturbance in 50% of users at higher doses.
It's a very rough side effect profile, yes.
And if you stop taking it suddenly, you can experience a dangerous rebound of high blood pressure. I mean, hot flushes already destroy a woman's sleep. Why on earth would the official guidelines license a drug that makes the primary collateral damage of menopause worse?
Your frustration is completely justified. And honestly, it highlights a dark era of historical desperation for non-hormonal options. Clonidine was effectively grandfathered in.
Grandfathered in how?
Well, decades ago, it showed some very modest efficacy in early trials. We are talking about reducing flushes by maybe 4 or 5 a day.
Wait, that barely moves the needle for someone having 20 flushes a day.
It barely moves the needle at all, and it comes with that 50% chance of sleep disruption you mentioned. But for a long time, it was simply the only non-hormonal tool that a pharmaceutical company had bothered to push through the specific regulatory hoops to get a formal license for vasomotor symptoms.
So it wasn't the best drug. It was literally just the only one with the correct paperwork.
That is a very cynical but largely accurate assessment of its history. Today, many menopause specialists rarely use clonidine as a first-line treatment.
I can see why.
Yeah, the side effect profile is far too harsh compared to the minimal benefit. This entire borrowed toolkit era has been incredibly frustrating because doctors were forced to treat the whole body just to turn down the heat.
Well, if we're just throwing darts at the entire nervous system and accepting all these miserable side effects, it makes me wonder, Did scientists even know what the target was? Like,
What?
what actually causes a hot flush in the first place?
For a really long time, we didn't fully know, but asking that exact question led to one of the most exciting breakthroughs in women's health in recent decades. Researchers finally mapped the specific neural pathway of the flush.
Okay, let's dig into that science. Take us inside the brain. What is actually happening the moment a flush begins?
The mechanism lives in a tiny cluster of nerves in the hypothalamus, which is the region of the brain that acts as your body's temperature control center. These specific nerves are called KND neurons, that's spelled KNDY.
KNDI neurons. Got it.
Think of KNDI neurons as the highly sensitive thermal sensors on that possessed house thermostat you mentioned earlier.
Okay, so they're the sensors taking the temperature readings.
Exactly. Under normal premenopausal circumstances, estrogen keeps these KNDI neurons calm. Estrogen acts like a regulator, ensuring the sensors only react when you are genuinely overheating.
Like when you're working out or something.
Right, but during menopause, when estrogen levels drastically fall, that calming influence is removed.
So the sensors lose their supervisor.
And they panic. The KNDI neurons become hyperactive and literally enlarge. They start firing off massive chemical signals, tricking the brain into thinking the core body temperature is dangerously high.
Even though you might just be sitting on the couch.
Exactly. The brain receives this false alarm and instantly triggers an emergency cooling protocol. It dilates the blood vessels at the surface of the skin to dump heat, and it causes sudden, intense sweating.
Which is the hot flush. It is entirely a false alarm. Here's where it gets really interesting, though. Once scientists figured out that the KNDI neurons were the specific culprits sending that panic signal, they didn't have to borrow bladder pills anymore, did they?
They didn't. They could build a drug from scratch to target that exact mechanism.
Yes, and that targeted drug is fezolinetant, which is marketed under the brand name Veozah. It represents a total paradigm shift because it is a neurokinin 3 or NK3 receptor antagonist.
That's the one.
Break down how that actually stops the KNDI neurons for us.
Well, remember that those KNDI neurons communicate their panic to the brain using a specific chemical messenger. That messenger is called neurokinin B.
Okay, neurokinin B.
Fezolinetant is designed to be the exact molecular shape to block the receptor for neurokinin B. It acts like a chemical shield. It sits on the receptor and physically prevents that false heat alarm from ever reaching the brain's thermostat.
That is amazing. It is a highly targeted, custom-built off switch. And looking at the data from the sources, the results are just phenomenal. It's prescribed as a 45 milligram once-daily tablet.
Yep, just one pill a day.
And in the Skylight Phase 3 clinical trials, which involve thousands of women, fezolinetant showed roughly a 60% reduction in moderate to severe hot flushes.
The speed of relief is also remarkable. I mean, with the repurposed antidepressants we talked about, patients often have to wait weeks for the drug to build up in their system before they notice a change.
Oh, right.
But with fezolinetant, women were seeing significant improvements in the very first week.
And because it only blocks that one specific signal, it's not messing with your bladder or your blood pressure or putting you to sleep.
Exactly. The side effect profile is vastly cleaner because it is so incredibly localized. It treats the symptom at its absolute root in the brain. This robust efficacy and safety profile is exactly why NICE recently published guidelines recommending it for routine use on the NHS in England.
So what does this all mean for the patient? If this drug targets the exact brain switch without using hormones, and it doesn't carry the systemic risks of HRT or the awful side effects of gabapentin, why wouldn't everyone over the age of 50 just take this?
It's a fair question.
Why isn't this the new default over hormone replacement therapy?
It is vital to understand the boundaries of this new medication. Fezolinetant is a brilliant surgical tool, but it only does one thing. It treats vasomotor symptoms, often abbreviated as VMS, which are your hot flushes and night sweats.
So it stops the sweat and literally nothing else.
Correct. Hormone replacement therapy, on the other hand, is a systemic treatment. Because HRT replaces the estrogen your body is missing, it provides a massive umbrella of protective benefits.
Wait, the broader health benefits.
Exactly. Protects bones from osteoporosis. It provides cardiovascular protection. It resolves vaginal dryness, joint pain, and the severe brain fog that many women experience during menopause. Fezolinetant cannot protect your heart or your bones.
Okay, so if you are suffering from a whole constellation of menopausal symptoms, HRT is still the ultimate multi-tool.
Yes. And beyond the lack of systemic protection, Fezolinetant is not a casual, over-the-counter fix. It requires strict medical supervision because of potential impacts on the liver.
Oh, really?
Yeah, during the clinical trials, researchers observed temporary, transient changes in liver enzymes in a small percentage of the women taking it.
How does that translate to the patient experience, though? Does it mean going into the clinic frequently?
It does. The current safety guidelines mandate liver function monitoring. A patient must have a baseline blood test before they can even be prescribed the medication. Then they have to return for monthly blood tests for the first 3 months of treatment, just to ensure their liver is processing the drug safely.
Well, that is a significant commitment. Taking time off work for monthly blood draws isn't trivial.
It's definitely a hurdle.
But understanding the limitations of HRT and the specific hurdles of these new drugs brings us to the population that needs these breakthroughs more than anyone else. Paradoxically, these are the women who have historically had the absolute fewest choices, breast cancer survivors.
Absolutely. Navigating menopause care for breast cancer survivors is perhaps the most challenging and high-stakes area in this entire field of medicine.
Let's paint the picture of what these patients face, based on the clinical guidelines. If a woman is diagnosed with hormone receptor-positive breast cancer, it means her tumors literally use estrogen as fuel to grow.
Exactly. The cancer feeds on the hormone.
So the primary treatments, drugs like tamoxifen or aromatase inhibitors, they're designed to actively block estrogen from binding to cells or to completely eradicate estrogen production in her body.
They are essentially forcing a patient's body into a sudden, severe chemical menopause. Natural menopause is a gradual decline of hormones over years. Chemical menopause is like falling off a cliff.
Wow, that sounds incredibly harsh on the body.
It is. Because that drop in estrogen is so sharp, the hot flushes triggered by these cancer drugs are often violently intense. They can be much more frequent and severe than what a woman experiences during natural menopause.
But because her cancer was hormone sensitive, systemic HRT is strictly forbidden. Giving her estrogen to cure the hot flush could literally feed any microscopic cancer cells remaining in her body.
It is an agonizing clinical catch-22. You have a patient who has just survived cancer, suffering from debilitating, intense vasomotor symptoms that ruin her quality of life.
Right.
And the most effective traditional treatment for those symptoms is the one thing that could threaten her survival.
Reading through these sources, navigating this specific minefield is just terrifying. I mean, a patient might naturally think, okay, my doctor says no HRT, I will just go to the health food store and use natural herbal remedies. But the guidelines explicitly warn against that.
They do, very strongly.
Herbal remedies like black cohosh, red clover, or soy isoflavones are totally off the table because they contain phytoestrogens.
Right. Phytoestrogens are plant-based compounds that mimic the molecular structure of human estrogen. And your body really can't tell the difference.
So popping a soy supplement could be just as dangerous as taking prescription HRT for these specific patients.
Yes. They can stimulate hormone receptor-positive cancer cells.
And the danger doesn't stop at herbal supplements. Let's say a doctor tries to use the repurposed toolkit we discussed earlier. Like, let's try an antidepressant to cool you down. The sources highlight a massive, life-threatening warning here regarding two very common SSRIs, paroxetine and fluoxetine.
This is a biochemical interaction that every patient and doctor needs to be acutely aware of. It involves how the body processes the cancer drug tamoxifen. Tamoxifen is what we call a prodrug.
Meaning the pill itself isn't the actual medicine.
That's a great way to put it. When you swallow a tamoxifen pill, it is biologically inactive. It has to pass through your liver, and your liver uses a highly specific enzyme called CYP2D6 to convert the tamoxifen into the active chemical that actually fights the breast cancer.
Wait, so the liver is essentially the manufacturing plant for the cancer cure. And what do paroxetine and fluoxetine do to that enzyme?
They are strong inhibitors of CYP2D6. They essentially shut down that specific enzyme in the liver.
So if a breast cancer patient is suffering from severe night sweats and a well-meaning doctor prescribes paroxetine to help her sleep, she's unknowingly shutting off the enzyme that activates her cancer treatment.
Yes.
Treating her hot flush could render her life-saving cancer medication completely useless.
It is a devastating interaction. The patient would have absolutely no idea it was happening until the cancer potentially returned. It underscores why you cannot just guess or prescribe off-label casually when dealing with menopause in oncology patients. The pharmacology is incredibly complex.
That is deeply alarming. It makes you realize the sheer weight of the decisions these women and their oncologists have to make. Are there any safe options in the guidelines for them?
Thankfully, yes. Specialized menopause care relies heavily on understanding these exact enzyme pathways. Within the antidepressant class, venlafaxine, the SNRI we discussed earlier, is the preferred option for breast cancer patients on tamoxifen.
Oh, good.
Yeah, it does not significantly inhibit that liver enzyme, so the patient can get relief from the flushes without compromising their cancer therapy.
And looking to the very near future, the sources highlight another incredible development that brings hope to this specific group.
Right.
We talked about fezolinetant, the new drug that targets the KNDI neurons. But there is a next-generation drug in the pipeline called elinzanetant.
Yes, elinzanetant takes the targeted approach and refines it even further.
The sources show elinzanetant is a dual receptor antagonist. It blocks both NK1 and NK3 receptors. And the data recently published in the New England Journal of Medicine from the OASIS clinical trials is absolutely staggering.
It really is.
It showed a 74% reduction in moderate to severe hot flushes. But the really amazing part, the part that matters most for this Catch-22, is that it was specifically trialed safely in breast cancer patients.
That distinction is paramount. Because fezolinetant is still so new to the market, long-term safety data specifically isolated for breast cancer populations is still being gathered. It isn't widely licensed for them just yet.
Which makes sense.
Right. But the developers of elinzanetant are testing it directly in this highly vulnerable group right from the start, and the results are incredibly promising. By targeting two neurokinin receptors, it also seems to have a pronounced secondary benefit of actively promoting better sleep architecture.
Which is a massive relief for patients enduring chemical menopause. It is incredibly empowering information. Whether you are navigating this transition yourself, maybe you've been told HRT isn't safe for your specific medical history, or perhaps you are supporting a friend or a partner through menopause or breast cancer recovery. Knowing that these highly specific, targeted options exist changes the entire conversation.
It really does.
You don't just have to smile and bear it.
The historical narrative offered to women has always been, if you can't take hormones, you just have to tough it out. Or, here's a blood pressure pill that will make you dizzy, good luck.
Right.
That is no longer an acceptable standard of medical practice. Patients have the right to ask their doctors about these specific neurological targets.
We have covered an immense amount of ground in this deep dive. Let's quickly recap the journey we've taken through these guidelines. Our mission was to find out if there are effective non-hormonal prescription options for hot flushes. The answer is a resounding yes, but the landscape is rapidly evolving.
Very rapidly.
We have officially moved away from the Swiss Army knife era, where we borrowed antidepressants, anti-seizure medications, and bladder pills that forced women to endure a host of systemic side effects just to cool down.
And we have firmly arrived in the scalpel era of treatment.
The scalpel era. I love that. Drugs like fezolinetant and the upcoming elinzanetant that act as neurokinin receptor antagonists, they target the exact possessed thermostat in the brain, the KNDI neurons, shutting off the false alarm while leaving the rest of the body completely alone.
If we look at the bigger picture behind all of this data, what this deep dive truly highlights is that personalized precision care is paramount. No two women experience menopause in the exact same way.
Not at all.
Some have mild symptoms, others have debilitating symptoms that cost them their careers, their comfort, or their sleep for a decade. Having a medical toolkit that includes both the gold standard hormonal options and these advanced non-hormonal scalpels allows doctors to finally treat the individual patient's unique biology, rather than just throwing a generic fix at a symptom.
It is a massive, overdue leap forward for women's health. And it leaves me with a final provocative thought for you to ponder as we wrap up. Now that science has successfully mapped and targeted the specific neural pathway for hot flushes, it makes you wonder about the limits of medical science.
Oh, absolutely.
What other inevitable symptoms of aging, things we just accept as the cost of getting older, are just waiting for us to find their specific neurological off-switch? If we can fix the possessed thermostat in the house without tearing down the walls, could the physical discomforts we accept as entirely natural today become completely optional tomorrow?